All right. After all that food talk, it might be tough to pay attention here for the next hour or so, but here you are, and you'll be captive here with us. It is 10 o'clock and time for us to get started here this morning. Again, for those of you just joining or who may not be familiar with me or who may not have seen in a while, my name is Randy Lober, your growth marketing manager here at Action Benefits, and part of my job is to help you grow your businesses. And well, all of my job is to help you grow your business, if I'm being frank. And one way we do that is by providing you with some regulatory updates on what is happening, what is likely to happen in the fields that you work in. Joining me today is the incomparable Chelsea Smith. Chelsea, say hi to the people before we get started.
Hi, everyone. Thank you so much for coming and joining us today to talk about some of the new rules that you're going to look forward to. Not in 2 weeks, not in 2025, but in 2026. I'm very interested to see what feedback you guys will have on some of the things we're going to talk about today. And I see some familiar faces I see all the time and some I haven't seen in a minute. So thank you for joining us. And any questions you have, throw them in the chat and I will answer them as soon as I can.
Yep, Chelsea and I will work together to make sure you leave here a well-informed agent who is ready to maybe, hopefully, make some good noise about the rules you might be seeing here. So that said, Chelsea, my screen is up. Everyone can see it. Yes?
That's what I can see.
Okay, well, I'm going to pretend they can all see it too. And if not, we'll just see what's going on. All right. So today's presentation is cleverly or not so cleverly, depending on how you feel about my sense of humor, titled New Rules or in the Same Game. Generally, each year, CMS takes a look at some things that are going on within the Medicare Advantage and Part D markets, makes some new rules to adjust, to align with policy outcomes that they'd like to see. And that generally means that we all end up playing by some new and different rules, but playing the same game here in the Medicare market. Particularly, we're looking today at rules that CMS has proposed for contract year 2026. And the reason we're talking about 2026 here at the end of 2024 is each fall, CMS publishes what's called its proposed rule for the next full contract year. They approve that rule, they finalize that rule in early spring. So April, May, we'll probably run another session a lot like this. It tells you what actually went into effect. But in between now and January 27th, you, the agent community, has the opportunity, along with the entire public, to give CMS some feedback on that rule and what you like about it, what you don't like about it. And I think there's probably going to be things that you have both feelings about here. So that said, where we're going today, we're going to talk first about some proposals that directly impact agents and how you do business. We'll also talk about some things that directly impact consumers. So what will your beneficiaries, your clients, see and feel right away? Third big lump of rules we want to take a look at is things that might impact the market more broadly. So they're going to impact things that happen around you. You might not see it or feel it immediately in how you do business or what rules you're being asked to follow, but you might see some premium pressure. There's some benefit pressures happen because of some of those regulations. We'll talk about those. And as promised, we will help you share help you make your voice heard, right? Help you write into CMS about these regulations. Last year, about 750 folks, some of you included, did comment on CMS's proposed rule. And we did see CMS read and respond to those rules. I actually went through all those responses, or responded to those comments rather. And we did see some of what we prioritized, what the industry at large complained about, essentially, incorporated and acknowledged in that final rule. So today's goal is really to tell you about what's coming, tell you what you can do about it and how you can make your voice heard, and hopefully we'll all have a collective impact on policy that we work under in 2026. To show you a little bit of the format we're going to work in here today, framing everything as the problem that CMS sees, and I want to be very clear that these are not problems that I see. These are not problems that Action Benefits sees here on the left side of your screen, but they are the problems that CMS has outlined that they want to address in the proposed rule. On the right side of your screen, for everything we talk about here today, you'll see their solution, or what they proposed as a solution for that rule or for that problem. To give you a quick example of how that might work before we talk about what exactly is going to impact you as agents, one thing that came out of last year is that when CMS tried to make final rules about agent broker compensation, eliminating overrides, right, and capping some of the percentages of income you can make there, there was a lot of ruckus in the industry, right? Lots of lawsuits filed, and eventually a federal court put a stay on that portion of the rule. But a lot of us were left wondering, well, wait a minute, does the rest of the rule still go into effect? What happens to all these other provisions? So CMS was very careful at the end of this year's proposed rule to say, these provisions here are all severable. So if you've ever had a joint lease with your college roommates or whatever, or any other contract, right? You know that when we talk about severability, we mean that if one part of the agreement is found illegal, unconstitutional, struck down, the rest of the rule still stands as written. So even if anything in this rule gets challenged, that we're about to take a look at here, once the rule is finalized, any part of this rule gets struck down, it will still stand. And so that's kind of the format we'll take today. We'll introduce the problem CMS sees in the market. We'll introduce what they propose to do about it. And again, we'll end today giving you an opportunity to chime in on how we can fix that or whether or not their solution is an appropriate one. So let's talk a bit about what impacts you. What impacts are you going to see in how you do business and how you market your business? And ladies and gentlemen, there's a few doozies here that you might want to pay attention to. The first thing is CMS is going to require more things on that pre-enrollment checklist so more things for you to talk about with each beneficiary before you can actually take that enrollment and conduct that enrollment. And generally, this comes from CMS's secret shopping and auditing of all those call recordings that we're doing, whether it's enrollment call or those marketing or sales calls. They believe in general that beneficiaries are poorly informed about all their options and are not generally aware of some of the programs and subsidies that could save them money on their Medicare costs. Now, for a little bit of context, a little bit of clarity on this, who is CMS auditing? Probably, if I had to guess, they have not come knocking on any of your doors in this room. What they are doing is they're auditing those call centers, right? Those kind of larger agencies with your Jimmy Walkers and your, everyone in your TV advertising. They're auditing calls going into those agencies, into those call centers, and saying, hey, you're not really telling beneficiaries about all their options. And so rather than enforce the rules that are already in the books, they instead introduce this new wrinkle. So what they propose to do on the pre-enrollment checklist is require a few more things. They're going to require you to talk about Part D low-income subsidies, require you to talk about Medicare savings programs, require you to talk about federal Medicare GI rights, especially for someone that is new to Medicare or someone who is experiencing a special enrollment period that may make them eligible for federal Medigap GI rights. And they'll also ask you to talk about the implications of switching from Medicare Advantage to traditional Medicare. In other words, they're going to really focus on and look for in auditing that the agent has told the consumer that they may be subject to medical underwriting, outside of any guaranteed issue rights or their Medicare supplement open enrollment period, those first 6 months of Part B and effective dates that they have to enroll in Medicare supplement. So they're adding a few more things to the checklist. They would also add a requirement that you pause for beneficiary questions before you actually take the enrollment. How they enforce that outside of call recordings, I am not entirely sure. But that is on the books here as well. They would, they're asking you to pause for beneficiary questions. So that's all well and good. We can add a few more things to the checklist, and generally in the spirit of making consumers more informed, a lot of people can get on board with that. Where you may see some more difficulty is that CMS also wants to provide some stricter marketing oversight. And here, if you think back to the Jimmy Walkers and your Joe Namath ads and everything, that you're entitled to Medicare benefits, or call me and talk about your Medicare options, and all those items out there, all those ads you're seeing out there. CMS is seeing a lot of misleading ads, again, in their eyes, that skirt the current content standard that requires review and have the intent of starting the enrollment chain. So their solution to this problem is removing that content standard. We'll talk about that more in a second with some clear examples. And they're going to broaden the scope of materials that require review by CMS. So when we talk about content and intent standards, there's two things right now that a ad or a social media post or anything else has that triggers review by CMS, or triggers the need for review by CMS. Currently, those are the content standard and the intent standard on the left and right sides of your screen, respectively. The content standard is all those things you know as a scrupulous agent that you can't directly talk about in your ads without carrier approval, right? You can't talk about benefits, premiums, or cost sharing in ads or social media posts, or so on and so forth. You can't talk about measuring or ranking standards, or you can't talk about specific rewards or incentives associated with that carrier, right? That's all benefit information that is part of that content standard of the plan. So broadly speaking, content standard relates to benefits. On the right side is where things is that intent standard. And anything that meets this intent definition, or of drawing a beneficiary's attention to a plan or plans, or influencing their decision-making process, or even influencing their decision to stay enrolled in the plan, right? If any of the material can demonstrate that intent, it would require review by CMS. So current state is, if you meet both these standards, if you have something that talks about benefit materials and you're encouraging enrollment or encouraging some sort of enrollment decision, requires review by CMS. What they are intending to do is eliminate that content standard and instead require anything that meets the intent standard to be reviewed by CMS and carriers. So anything really that draws the beneficiary into an enrollment chain, or would be likely to draw beneficiary into an enrollment chain, is subject to review under this proposed rule. More practically speaking, what does that mean? There are probably some common things that you see on TV, or you may even be using in your own communications and ads to folks. So they call us some very specific examples of things of ads that would not require review under this rule. Like, do you know if your Medicare benefits are changing? Call now to speak to a licensed agent, or call me to discuss your Medicare options. Explore these new benefits, right? Implying that there's something else that would attract or allure people to investigate those plans. Or even just the kind of innocuous questions about Medicare, call 1-800-LEARN-MORE. Or substitute your agency's name or your direct contact number in there as well. So as you can see, right, anything that would potentially start a beneficiary down the enrollment chain, is what they're calling it in the rule, would now require review from CMS and from the carriers. Practically speaking, what that means for you is you're likely going to be using more carrier-generated material here. And gosh, if there were ever a good reason to add a national carrier like a Humana or a UHC to your portfolio, pretty good reason to do so, because they do have a lot of materials that maybe your local regional carriers do not. And of course, just because you advertise using that carrier's materials doesn't mean you have to make an enrollment in that carrier's materials, or in the carrier you're advertising there. So a big important change here, right? That advertising your business, talking about how you can help people with their Medicare options or weigh their options, any of that language now would require review by the carriers in CMS.
It feels like a lot of the really good marketing tactics that you would use in advertisement are now being targeted by CMS. And I know a lot of the things that I used to tell people when they would call me and say, hey, is this advertisement okay? A lot of the things I would say to like get around the rules that were already there are now going to be covered by this new rule. So really be careful. And yes, I'm glad you mentioned the national carrier thing, because that would be my go-to solution in this particular case. Is like, oh, just for now until you can get something approved, just go run to your Humana or your UHC, get some of that pre-generated advertisement content to support yourself in the meantime.
Yeah. The other thing that kind of falls into this direct agent impact, even though it might be kind of on the fringes here, and we see some chats coming in, we'll address those in just a moment here, is the administration and marketing of supplemental benefits. So these are all those things that are not the core medical benefits. These are your dental, vision, hearing, and particularly the debit cards you might use to help offset some of the costs for those benefits. And CMS, through looking at advertisements and what is approved and what, frankly, what it hasn't seen approved as well, sees a lot of plans and marketing agencies or TPMOs, including independent agents and brokers. They see them really advertising debit cards as the benefit here and not the mandatory supplemental benefits that the debit card is meant to administer. So meaning they're seeing a lot of ads saying, hey, get $60 a month, when you enroll in this plan, as opposed to use money to offset your dental, vision, and health expenses. So they're really, frowning upon the idea that, the card itself is the benefit. So what they propose to do about that is require steps to increase the user friendliness of debit cards. So they want to make sure that when a plan is using debit cards or a stored value card or prepaid card to administer supplemental benefits, or whether it's an OTC benefit or to reduce cost sharing on dental, vision, or hearing that's included in that base core Medicare Advantage plan, that has got to be user friendly. And they want to be able to make sure that if for whatever reason the beneficiary can't access that debit card, can't use it, whether it's user error or something else, that there is an acceptable reimbursement policy in place as well. So in other words, they could, if they had made an OTC claim, right, and wanted to use those dollars, they could get a cash reimbursement for their OTC rather than having to use the OTC debit card. The other thing that you're going to see in this rule is they want to limit the ability to market the dollar value or method of delivery. So a few moments ago, you heard me say things like, get your $60 a month Medicare Flex card or a no-cost debit card with all plans. No longer will, under this proposed rule should go into effect, would you be able to say things like that, or no longer would plans be able to say things like that either. So, because again, CMS really wants to put the emphasis on the supplemental benefits, not the actual cash value of whatever card might be associated with that plan, which frankly can be a pretty big, determiner in how you talk about those plans and how you talk about those with beneficiaries. So as far as what impacts agents, those are some of the three biggest things that we're seeing here in this proposed rule. Again, it's only a proposed rule. No promises it will go into effect, especially with a new administration coming in. But this is what can go on the table and things we should all be aware of. And we'd like to hear from you a little bit as we check out the chat here as well. What seems most noteworthy at this point, or is there anything that's kind of raising yellow or red flags for you at this point? And I see a lot of the conversation in the chat here revolving around what are some things that we could use. And Chelsea's exactly right. It's going to be difficult to say. And given the incoming administration's likeliness to be a little more friendly, frankly, to Medicare Advantage enrollments and so on and so forth, there's serious questions about whether this part of the rule will actually go into effect as written. But assuming that it does go into effect as written, we kind of have to make a little bit of a wait and see there. But you'd like to be safe in advertising yourself as an insurance agency, so on and so forth, and advertising your expertise in the area. It's just that you would not be able to have that explicit call to action that says, call me about your Medicare options, because that's what they see CMS is saying as entering that enrollment chain. Do you see a question that has come in here as well? Yeah, David's question that just came in, a button that says, ask me about Medicare would not be allowed under what we are seeing here. Yeah, I would say that's an accurate interpretation so far. Again, rule's not final yet, but that makes a ton of sense, David. And I saw another chat come in here as well. William asked about the pre-enrollment checklist, and yes, my understanding of the rule so far is that you would not capture those items in the scope of appointment. So you wouldn't capture LIS or Medicare savings plans in the scope of employment. They'd instead be on the pre-enrollment checklist that both you and the consumer have to acknowledge. And those are in many cases in your carrier enrollment kits at the moment. So I would imagine carriers would adapt to that. They'd add those line items on the pre-enrollment checklist, and you'd be off to the races from there, is how I would anticipate at least carriers would respond to that particular rule.
I would assume that Sunfire as well would add something, because I know that there's spots in Sunfire where it asks you like, hey, what prescriptions does your prospect take? What doctors are you using? So I would assume that that would also then be added into enrollment tools like that, where it would prompt you to ask those things before you continue on.
Right. So yeah, just like your paper enrollments have that same functionality, enrollment platforms like DRX, Sunfire, Health Sherpa for Medicare, they all have their own kind of version of the pre-enrollment checklist. It's fairly standardized at the end of the enrollment process, or before you start the enrollment process, rather, after you finish sold the quote, or presented the quote for that matter. And yeah, I would imagine that would be built into your workflow. So it'll be there, right? It'll be there for you to talk about, but whether we will do our part to help you shore up your knowledge and be able to put all of those new things, right? Or those things that kind of float around in the back of your head into agent-friendly and consumer-friendly language. We have a session coming up in January actually on what those Medicare savings programs, what they look like. Marty, excellent idea. We can certainly work with you on some scripts or at least some bullet points to help talk about each program.
Also, I'd like to add that we do have videos on YouTube as well to help you explain some of those low income subsidies and Medicare savings programs.
Yep.
Extra help. We have all those on YouTube you can use as well.
Yep, and importantly, if you, they are not Action Benefits branded. They are on our YouTube channel, but if you wanted to beg, borrow, and steal them for your own use, just to take a look at or to share with your prospects or beneficiaries for the moment, we could do that. I would also imagine that, I don't know necessarily about the regional carriers because they're a little slower on the uptake in this regard. But one thing I do like about both what Humana and UHC do in this market, and especially Humana, is they have a lot of videos within their advertising center, their marketing material center, that take care of a lot of the sort of compliance stuff for you. And I would imagine, though I cannot guarantee, but I would imagine they would also add to that. So again, whether or not you end up with a sold Humana plan at the end of the deployment, at least you've got some of that compliance stuff taken care of for you up front. And you focus on what you do best, and that's a needs assessment and matching the client with a plan that fits their needs. Speaking of clients, let's talk a bit about what might affect them. Sam, before I go forward, you saw Sam's notification come across my desk. My understanding is yes. So you can still market your affiliations with the carriers you represent, same way you do now, essentially, so long as you follow all of the carriers' rules about that. Like UHC, for example, is very particular about who uses their logo and when. But I would, yeah, what Chelsea says, exactly. Don't use logos and stuff without permission or acknowledgement. And sometimes that's not always an explicit opt-in where they have to give you permission. But UHC, for example, asks you to register your website with them before you use their logo. And so it's not a permission, it's more of a, hey, I'm going to do this. And Chelsea's right, rather be safe than sorry. Anyway, consumers, what's coming down the pipe for them? What are they going to feel? CMS right now thinks it's too hard for the average consumer to verify provider participation. Provider directories, as you all know, are a hot mess. There's ghost networks, providers that may or may not actually be still participating, and they can all change up at the drop of a hat. CMS also recognizes that a lot of plans who do administer at-home or in-home benefits, think about companion care like Papa Pals or so on and so forth, or in-home meal delivery and those sorts of things. Those are not listed on provider directories anywhere, and so beneficiaries really have no idea who's coming to their house. or who will be in their house provide some of those services. So CMS has two proposed solutions to that. One of them is to require carriers to upload their provider directories to CMS so that CMS can in turn add that functionality to the Medicare Plan Finder or Medicare.gov, and would CMS would also require those directories to be updated 30 days after any change that occurs. So if a single doctor drops out of the network, the carrier would be obligated to upload a new file and update their entire provider directory ready for Medicare.gov. And I think that's probably a welcome change, a good consumer protection for a lot of folks, at least insofar as that you can require carriers and enforce that they keep their directories up to date. The other part of that is any service or any supplemental benefit provider, whether it's a DME outfitter, whether it is a companion care, so on and so forth, all of those would be required to be included in the provider directory, either in that core file or on a supplemental list. Again, so beneficiaries have more information about who might be coming to visit and render whatever services are part of that plan. There's also a few things CMS is doing to implement portions of the Inflation Reduction Act first. So there's no real problem here other than them just implementing the law. And no real news here other than things for you to be mindful of talking about with your clients here going forward. First thing is that they remind everyone that vaccine cost sharing has been removed for all adult vaccines. So those approved by the Advisory Committee on Immunization Practices, and those approved vaccines are not subject to the Part D deductible, if the plan does have a deductible. The new wrinkle here, insulin cost sharing at $35 a month, of course, has taken up a lot of oxygen, especially for your clients and beneficiaries who might have diabetes. But they do add two more proposals in here that are interesting here as well. And they had proposed that insulin cost sharing would be capped at the lesser of one of these three figures for your on a per client basis. A, either $35 a month. B, 25% of the Medicare negotiated price. Again, remember that Medicare has negotiated that prices for 10 drugs. That will go into effect in 2026. So they'd cap cost sharing at 25% of whatever that negotiated price is. Or if the MAPD or the PDP has negotiated price for that, they would cap cost sharing at 25% of that price as well. So again, really doing some part at least to protect beneficiaries out-of-pocket exposure here for insulin. Though, as we all know, when you make carriers pay for more benefits or pay more to administer a benefit, that's going to come up in premiums or somewhere else later. The Medicare Prescription Payment Plan has so far been, at least to your CMS tell it, has been successful. They like what they've seen and heard about it. They've had good feedback from beneficiaries. But what they do realize is that currently, under the current set of rules, beneficiaries must re-enroll in that plan each year. Meaning each year, assuming they stay with the same carrier and same plan, they need to go back to the carrier and say, hey, yes, sign me up for the plan again. Sign me up for the plan again. So remember to do that January 1 if you have beneficiaries taking advantage of this program. What they would propose to do effective in 2026 is to allow for auto re-enrollment each year. So from 2026 forward, if you have opted into the program, you would stay opted in until your beneficiary chose to opt out. Makes life a little bit easier, hopefully one less form for your beneficiaries to fill out if they're taking advantage of that program going forward. Another fairly big deal here, again, that would directly impact your beneficiaries and going forward is anti-obesity medications. So under current law, and well, to be more precise, current interpretation of the law, Medicare is not allowed to cover any weight loss drugs. But recognizing that obesity is soon or quickly becoming classified as a chronic condition, and that there are a significant portion of Medicare eligibles who are obese, They're proposing to reinterpret that law to allow coverage for drugs that do treat obesity, like your wegovys and your ozempics and so on and so forth. And they would expand that reinterpretation to the Medicaid program as well. Now, we should point out that this would only be approved for beneficiaries who are clinically obese, and it'd be used to reduce, when the drug is used to reduce excess weight or to maintain that weight reduction over the long term. Chelsea, I know you had a few more things to say because this was an area you did a little more research on.
Yes, so the language here is important. Your beneficiary is not going to be able to get this prescribed to them to get like summer ready or anything like this. This is only for if their doctor finds them to be clinically obese and that weight loss is going to be something that's going to prevent something else like a heart attack, stroke, etc. This is not for a little bit overweight or whatever. This does not negate anything covering diabetes. So if your client already has this cover for diabetes, nothing's going to change there. That was already a thing. Nothing changes. And I will say too, I read some of the comments already that have came in. And this is so far the #1 commented on rule, believe it or not. The proposed rule, I guess, so far. So I'll be curious if this goes through. But it's going to be supposedly saving us a lot of money in the Medicare realm long term if they're able to stay on these medications, and these medications actually do help prevent a lot of these dread disease, bad things happening to them over time.
Yeah, so we'll see how that turns out, especially with the new administration coming in and figuring out how they would choose to approach this and cover this. Another thing your beneficiaries might see and might appreciate is CMS's commitment to behavioral health access and promoting behavioral health access. And although Medicare Advantage plans are required by law to cover everything that traditional Medicare does, what CMS has found is that on average, Medicare Advantage enrollees pay between $7 and $21 more when they seek in-network mental health services, whether that's therapy, counseling, when you look at even inpatient hospitalization figures, so on and so forth. And they especially find that substance treatment programs or opioid treatment programs are especially more expensive for Medicare Advantage enrollees than they are traditional Medicare enrollees, on average about $37 more per visit or per treatment. So instead, what they propose to do is to cap the cost sharing for Medicare Advantage plans and 1837 cost plans to coincide with what someone would pay on traditional Medicare for those levels of treatment. So this chart I know is a little tough to read, but I pulled it right here from the proposed rule to show you a little bit about what they're talking about. Here in contract year 2024, we're looking at column C here. So the third column from the left. You're seeing on average what beneficiaries pay for those services. So mental health specialty services, for example, have about a 24% co-insurance rate, cost beneficiaries out of pocket $41.92 if they're on a Medicare Advantage plan. Column B, just to the left of that, shows you what they would pay under these proposed rules. So they'd have a straight 20%, Part B co-insurance like they do for anything else, and a $35 copay for that plan instead, or a $35 copay for that plan instead, depending on that MAPD structure. So it'll line up a little bit more closely with what you'd see on traditional Medicare. Again, I guess what I would caution here is that yes, you may see lower out-of-pocket exposure for your clients who seek behavioral health, and that's a welcome thing. We all need to promote, our own mental well-beings, and especially, as substance abuse, that epidemic is now lightening. But when you ask carriers to cover more things and require less cost sharing, well, the toothpaste tube can only be squeezed so much, right? So are we going to see higher premiums? Are we going to see other benefits cut? I just don't know, which way benefit carriers will go, but it's a good there's a strong likelihood that if this measure comes to pass, you're going to see even more benefit adjustments come in 2026. Some other good news here, and I don't actually have any buts to add to this one, is some enhancements for D-SNP enrollees. Right now, CMS does see a fairly fragmented experience, especially when the enrollee does not have the same carrier for both Medicaid and their Medicare coverage. And because that experience is so fragmented, there's really a difficulty in accessing benefits for dual eligibles. So in locations where either highly integrated dual eligible plans or fully integrated dual eligible plans are available, the member will now be able to use one ID card for Medicare and Medicaid services. And the health risk assessments for those two programs, right now they're two separate HRAs for Medicare and Medicaid. If the member is involved in either a FIDE or a high D-SNP, fully integrated or highly integrated, they would only need to take one health risk assessment to satisfy those requirements and help adjust the risk and payments and so on and so forth for that carrier and get them support that they need. So two, on the whole, good adjustments that for D-SNP beneficiaries. Chelsea, I know you had a little bit to say about that as well.
It couldn't have come at the right time because that's what we're getting them in Michigan here, the FIDE and HIDE SNPs in 2026. So works out for us.
Yeah, absolutely. So we had a little bit talking here about things that could directly impact your clients. Is there anything you're seeing that seems most likely to help your clients? We'd love to hear what's on your mind as you chime in, and we'll head to the home stretch and talk about what's going to happen to the market more broadly.
My grandma's going to be really excited that she doesn't have to use more than one card for her D-SNP. So I'm going to be excited because she won't call me and ask me where her cards are. What's going on with my cards?
Yeah, I mean, for a lot of D-SNP enrollees, especially, as they take advantage of their ability to enroll in plans and change enrollments in plans fairly frequently, they end up with just like a whole deck of a literal deck of cards of all their ID cards. They just go to the doctor's office and throw them on the desk and see what happens, right? So having one ID card where possible does make a lot of sense. Let's talk a bit about what is going to impact the market a little bit more broadly. What are you going to see and feel happening around you, even though it may not directly impact you? First thing we want to touch on is MLR oversights, or medical loss ratio oversight. Turn into Sean Connery for a minute there, sorry. But generally what CMS sees is that how MLR is calculated in the Medicare Advantage space is not in line with how it's calculated in commercial plans or ACA plans and other products. So they want to do a bit to bring that more in line. They also noticed that current data collection methods and the way they currently ask people to calculate MLR, their medical loss ratios, can allow big conglomerates who are deeply and vertically integrated to manipulate their MLR a little bit. What I mean by that is, say you have, I don't know, a giant carrier with that kind of has a purple as one of their primary colors, or a bluish purple as one of their primary colors, and they own everything in the entire healthcare distribution channel, from the insurer down to the pharmacy benefit manager, down to the actual hospitals, down to the doctor practices, so on and so forth. What CMS suspects is that there are some shell games being played with the money there. So to manipulate MLR, to make it look like they're either paying out or they're crying poor on their benefit payouts here, or their claim payouts, that may not actually be the case. So they propose to rework the MLR formula to better align with that. And they do request information from folks about how that vertical integration that we talk about, so one business entity owning the entire healthcare distribution chain, how does that actually impact MLR calculations? I expect we're going to see lots of payers weigh in on that, lots of insurers weigh in on that. Generally, what this means is they're going to include some new things and exclude some things from the MLR ratios. So they're going to include provider incentives and bonus incentives in the top part here of the MLR ratio. And they'll include unpaid Medicare prescription payment plan balances, right? So remember, in the Medicare prescription payment plan, the carrier actually fronts the money to the drug maker for those drugs, and your beneficiary pays the payment or pays the carrier in installments. They'll be able to carry all that unpaid money as a liability on their books when calculating their medical loss ratios. They will be asked, though, to exclude any administrative costs from the top half or their numerator from the MLR. So again, we'll be seeing some changes in that, which can affect earnings reports and how people in general perceive the financial stability of these carriers going forward. Another thing that your beneficiaries might welcome is some additional pharmacy transparency. CMS recognizes that beneficiary access is not consistent, and oftentimes, because of the way pharmacy contracts and carrier contracts work out, is that enrollment decisions often get made on bad directories. A pharmacy that, for example, that's in network when you sign someone up during AEP may not be in network come January 1 when the plan actually goes into effect. And CMS has found, as they've audited Part D payments, that a lot of pharmacies and a lot of PBMs aren't actually granting people access to the Medicare negotiated prices, or won't have the ability to negotiate to grant access to Medicare negotiated prices going forward. So there's a few things that CMS would like to require in 2026. First of all, is that Part D plan sponsors, whether it's an MAPD or a PDP, will tell each pharmacy by October 1st of each year whether they'll be in network with that plan and for what plans by October 1st of the prior year. Pardon me. They also will allow pharmacies to terminate their contracts with the plans without cause, as long as they give the carrier the same amount of notice the carrier would have to give the pharmacy according to their contract. And they will require all pharmacies to enroll in what's called the Medicare Transaction Facilitator, because again, they want pharmacies to be able to see those negotiated prices and give those negotiated prices to beneficiaries when those prices go into effect. AI is everywhere, including in your Medicare Advantage insurers. And what CMS has seen is that there is no real strict guidance on how AI is being used. And unfortunately, it is being used a lot in prior auth and in claims denial decisions. And there is some evidence building that AI is making discriminatory decisions when it is doing so, or when it's empowered to do so. So CMS has to write this rule in law, although you would kind of think, well, yeah, that makes sense, right? They would like to require the use of AI to comply with all current anti-discrimination regulations. And they would like to remind carriers that cannot discriminate on any factor related to a person's health status when making a coverage decision. So kind of like yeah, that makes sense, but people, if you don't put a rule into writing, then it's easier to break. The last thing that might impact the market more broadly is health equity and prior authorizations. Currently, CMS just last year did require carriers to publish publicly reports on the prior authorizations and denials. But that reporting does not require them to break that down by line item services. So what did we deny care or coverage for? Or by social risk factors, like by low SES, or by race, or by so on and so forth. So CMS would like to ask carriers to be even more transparent with that data in 2026 and forward, and require them to demonstrate which populations were denied care due to a pre-auth or a claims denial. So they'd be looking at people with special needs. They'd look at groups with low socioeconomic status, so on and so forth. And they would also ask carriers to break out in that reporting which services and line items, not line items, line items they denied care for. The idea being that if we could see, for example, that people with special needs are often denied XYZ service, that allows CMS to, and the general public, frankly, to go, why? What's going on there? What's different about that population? And hopefully hold carriers more accountable for providing more equitable care. So I would like to hear a bit from Chelsea and the rest of the room. What seems most likely to impact the market at large here before we take a sip and take a sip of water and can tell you how to make your voice heard?
I know especially in my neighborhood or my neck of the woods, a lot of pharmacies have been just straight up closing down. And it's not like the mom and pop ones exclusively either. It's a lot of like the CVS by my house closed the other day. And even I was affected by that. I'm like, oh, now I gotta find a new pharmacy. Because I just picked the one that was most convenient for me that was in my network. And so I think that this checking in on all these pharmacies and giving them more rights, I guess, I think is gonna be helpful for some of the reports that we've been seeing, not exactly related to this, but how pharmacies are getting harder and harder to come by at a physical level for our beneficiaries. And unfortunately, a lot of the solutions that are being offered, the mail-in pharmacies or the delivery pharmacies, that kind of jazz, they don't want to do that. Like they just don't want to. Like they understand that it exists, they know it's convenient, they just don't want to do it. So I think having these pharmacies have more freedom to support themselves or stick up for themselves, I guess, is gonna be really helpful.
Yeah, I think so, right? For a lot of folks being able to get out to go to the pharmacy or go to the local, mom and pop store, that's a big source of social connection, right? They don't want to, have their drugs delivered in a faceless box. All that said, ladies and gentlemen, lots of stuff we talked about here today. I want to also tell you how you can make your voice heard and tell Uncle Sam exactly what you think about this. I did say I read all 750 comments on last year's rule, and what I did notice was a lot of form letters from field marketing organizations and other uplines. And CMS commented on that when they made the final rule, actually, and said, gosh, a lot of people seem to say the same things. And it was tough for us to figure out whether it was a genuine critique or whether there was some, mass campaign to get thoughts out there, right? So we do not and have made the decision to not necessarily give you a form letter to make your voice heard. We think there's more power in when you do make your voice heard, and if you want to make your voice heard on these regulations, that you do so in your own words and express, really what it is that you particularly are concerned about. CMS, at least in recent rulemaking, has seemed to take those more genuine reactions into account when at least replying to or making some decisions on the rules. That being said, public comment is open through January 27th, and it's available to you on the Federal Register here. You are able to review the entire document as you like. So I know we just spent 45 minutes summarizing the thing, but if you'd rather read all 700 and some odd pages of it, knock yourselves out. What's most important, though, is in that top right here in that green is a submit a public comment. That will take you to where you can tell Uncle Sam exactly, again, what you think about this or not. And Chelsea has been kind enough to put that link to this article directly in the chat for you. So again, you can make your voice heard. So what does this all mean for you? Well, if I had three big takeaways from my reading of the proposed rule or our reading of the proposed rule, definitely what we talked about up front, marketing your agency gets tougher if this rule goes into effect as written. And while we'll always be here to support you with that, again, we all have to play by the same set of rules, and we'll have to think together and kind of reinvent parts of the wheels as how we help you, promote yourselves and how you promote yourselves to beneficiaries and prospects. Second thing, we see in general is that consumers are going to see some out-of-pocket cost savings if this rule goes into effect, especially when it comes to behavioral health, right? But as we saw with the Part D redesign this year, consumers saw less out-of-pocket expenses, but what happened on the other side? Lots more exposure and premium. Lots more monthly out-of-pocket costs to just access those lower out-of-pocket costs. So is it a case of robbing Peter to pay Paul? I'm not sure, but that's possible coming forward. But what there is here to appreciate is there's definitely a push for more transparency throughout the system. Personally, this is me talking, not Action Benefits talking, even though I have the logo over here to my side. Love the idea that carriers are going to be required to report more on prior authorizations and how those and claim denials and how those are impacting folks. I think that's a kind of this opaque black box that we can't see into at the moment. And making that material come to light, I think, can only help people understand what's really going on when carriers make these decisions. All that said, I do thank you for your time and attention here today. We'll go ahead and take a look at chat and any questions you might have here in a moment, but you are always welcome to talk to us here at Action Benefits. You can find us at LinkedIn at the Action Benefits Company. Email Chelsea and I directly at learning@actionbenefits.com. That's our team mailbox. We'll be able to dig into everything with you, or get a hold of us on our main line at 248-356-8585. Chelsea, anything to say to the people while we take a look at some of the chat that's going on here?
Oh, sorry, I lost my mouse there for a second. But I will say, if you are interested, the comments, some of them are available to read already, and that was already, it was super fascinating last year, and believe me, it is also fascinating this year to look at what fellow agents have to say on some of this stuff. And it's particularly interesting because it's all over, I hear what you guys have to think all the time, and I love that. It's my favorite part of my job. But you guys are kind of centralized to my area, so I kind of hear things that only affect me. And it's very interesting to kind of go look and see what affects like Florida or like Kansas or the nation as a whole, and hear things that I didn't really ever think about before.
Yeah, absolutely, right? We will do a deep dive in the comments here once the comment period closes on January 27th, and kind of put in front of you a little bit about what the pulse of the nation is here, whether it's directly from insurance agents, whether it's from insurance payers. We'll kind of recap that for you and do some of the heavy lifting for you and give you a sense of what's going on here in the market. All that said, yes, we'll get the slides to you. We'll also get you this recording so you can hear everything word for word should you choose. About 24 hours from now, it'll appear in your inbox at the email you registered with here today, and whether you're here or not. So folks who maybe didn't make it but registered will get the recording in their inbox as well. And same for any webinar that you come to with us. On behalf of Chelsea, though, and on behalf of the entire team here at Action Benefits, we'd want to thank you again for your time and attention here today, and spending some time getting to know some of the critical rules that may impact your industry going forward. We also wish you all a safe, warm, happy, and healthy holiday season filled with all the attention and gifts you could want from your loved ones and with your loved ones here. And look forward to seeing you all after the new year. Thank you and enjoy your holiday season. We'll see you all again soon.
Happy holidays, everyone.